Hello everyone, today let's talk about male infertility. Unfortunately, nowadays, the woman is the first person to be blamed whenever there is a case of infertility that we come across in the clinic. That is the social stigma that is attached to it. But in reality, you will see that the male is equally responsible for infertility as that of a female whenever we look at the various etiologies and the percentage of these etiologies causing infertility. It's just that they're not investigated or we don't look into those causes that often. Okay, that's why they say male infertility is invisible unless it is investigated. So having said that, let's look at a few definitions. Talking about infertility, infertility is defined as it occurring when 1 year of unprotected intercourse does not lead to conception. That means in spite of having regular intercourse for 1 year, if the couple still does not conceive, then we term it as infertility. Subfertility basically means this is for the couples who exhibit decreased reproductive efficiency. So in infertility, there is no conception. We are talking about those who don't exhibit enough reproductive efficiency. Next, there are two other terminologies. One is fecundability, one is fecundity. Fecundability is basically the probability of achieving pregnancy within a single menstrual cycle. That means what is the chance of this particular couple eventually ending up in pregnancy. Now this pregnancy can either get aborted or can go on and become a live birth. I hope you're getting the point. Now fecundity is about talking about that particular live birth. Okay, it is a part of your fecundability. So fecundity is the probability of achieving live birth within a cycle. So fecundability means just pregnancy. The pregnancy can either get aborted, can get terminated, or can go on and have a delivery. Okay. Whereas in fecundity, we are talking about the probability of achieving a live birth within the cycle. Next, let's talk about spermatogenesis. A few points. During embryogenesis, the number of sperms that are there are roughly 300,000 in each gonad. Okay, so there are two gonads, so 300,000 spermatogonia in each gonad. Now this number will keep on increasing, they keep on multiplying. So by the time the child or the teenage reaches puberty, that number can reach 600 million spermatogonia in each testis. You can just see the exponential rate at which these spermatocytes are multiplying. Now these sperms are produced in what we call as the seminiferous tubules. This is within the testis. And a very, very important cell in your seminiferous tubules are your Sertoli cells. Okay, so this is where the sperms are produced, okay, within the seminiferous tubules. Now, the process of this production of the sperm roughly takes about 70 days. So, spermatogenesis takes about 70 days. Now, by the time that particular child becomes a teenage and becomes an adult, they start producing about 100 to 200 millions of sperms each day. Okay, at any given point of time, every day, they tend to produce 100 to 200 millions of sperms. Now, the sperm production happens within the testis. Okay, it happens within the testis, within the seminiferous tubules. But the spermatocytes which are produced then go into the epididymis, and that is where the maturation happens. That is where the maturation happens. And from there, they get transported via the vas deferens. Okay, transported via the vas deferens. So if you see from the testis, it goes to the epididymis. From the epididymis via vas deferens, it is going to go. Now there is something called as the seminal vesicle. Okay, the seminal vesicle joins this vas deferens, and they have a common channel for some time. This is called as the ejaculatory duct, and then this empties into the prostatic urethra. That empties into the prostatic urethra. So in short, this is where the entire or the full semen is there. So if you look at the contents of semen, it basically gets secretions from three different places. One of it is the testis. This is where the sperms are coming from. Then it gets a secretion from the seminal vesicles. And the last one is your prostatic secretions. So there are three different secretions which are seen whenever we are talking about semen. Just keep this in mind. We will be talking about it in some time. Now, so far we spoke about the cells within the testis which help in spermatogenesis. There are other cells in the testis as well, and one very important cell is your Leydig cell, and this is what secretes testosterone. Now, this testosterone plays a very important role in spermatogenesis because it stimulates the spermatogenesis. One additional point that you guys need to know about, there is Leydig cells, there is Sertoli cells. Okay, Leydig cells produce testosterone, Sertoli cells produce the sperms. Remember S for S, Sertoli cells produce the sperms. Now, whenever there is any sort of insult to the testis, okay, be it an undescended testis, be it some sort of thermal damage, be it radiation, be it chemotherapy, whatever it is, or even a torsion of the testis, that means some amount of hypoxia. At any point of time, whenever there is an insult to the testis, the Sertoli cells are very, very sensitive. Again, S for S. So, the first cells to die down are your Sertoli cells. That means, at the first site of insult, the sperms start getting hit and it can lead to infertility. On the other hand, the Leydig cells are very, very resistant to all these damages. So, the Leydig cell remains intact until the last stage or until the end stage. That is when the Leydig cells start to die. But otherwise, they can resist all these insults or they can resist all these damages. So, in short, even though the patient is infertile because of lack of sperm production, but testosterone production remains normal. Why? Because the Leydig cells are resistant. Now, the patient might be infertile, but the secondary sexual characteristics will remain normal. Why? Because it is the testosterone that is being the reason for the secondary sexual characteristics. So, in short, if a patient has cryptorchidism, that means undescended testis, theoretically the testis should not be working. So, in such a scenario, you expect the patient to have infertility and to have certain female-like characteristics. Why? Because the testis is not functioning. So, there should be no testosterone. But in reality, the Leydig cells will survive. So, they will produce the testosterone. So, secondary sexual characteristics will remain intact, but there will be infertility. I hope you're getting the point. Okay, so remember, Sertoli cells produce sperms. They are sensitive, okay, and they die down first. Whereas the Leydig cells secrete testosterone. They can survive for longer time, and they are the ones which are responsible for the secondary sexual characteristics. Now, let's look at the percentages. Okay, this is basically the relative prevalence of the etiologies of infertility. Okay, isolated male infertility, that means where male is the sole reason for the infertility, is about 20 to 30%. But if you look at a combined percentage where there are many cases where even male is also equally responsible for infertility, that time it goes up to 50%. Okay, half male, half female. So, the responsibility of infertility can be because of both the sexes. Next is, if it's an isolated female factor, that can be around 40 to 55%, and unexplained infertility, that accounts for about 10 to 20% of all causes of infertility. Now, let's look at the etiologies. That means, what are the causes for male infertility? Now, there are two ways of classifying it. One is the anatomical way, and the other one is basically a mnemonic what's given in Campbell. We'll look at both of it. Okay, nothing great, but it's just whichever you find easy to remember, you'll have to follow that particular system. So, first, let's talk about the anatomical way. Before we talk about the causes, let us look at what exactly happens. So, we have hypothalamus. The hypothalamus secretes the GnRH, gonadotropin releasing hormone, that in turn acts on the pituitary gland. The pituitary gland in turn secretes FSH and LH, and this in turn acts on the testis. Okay, now testis is where spermatogenesis occurs, and these sperms that are produced eventually travel via the epididymis, the vas deferens, the ejaculatory ducts, and finally into the prostatic urethra. Okay, so finally into the prostatic urethra. That is the way in which the sperms leave the human body. Now, if there is a problem in either of these various areas that we spoke about, this can lead to infertility. Okay. Now, if it happens here, that means if there is an issue with the hypothalamus or the pituitary, these hormones are not secreted, so they don't stimulate the testis. So, if the testis is not stimulated, there is no spermatogenesis that occurs. Okay. So, whenever the testis is not functioning, we call it as hypogonadism. Now, the testis is not working because of lack of stimuli. Not that the testis doesn't want to work. The testis is interested in working, but it doesn't have the stimulus needed to work. So, that's why we are going to call this as a secondary hypogonadism. Okay. And this is classified as pretesticular. That means above the level of testis, if there is some issue, that's called as pretesticular. Now, the conditions are basically your hypothalamic pituitary diseases. And this accounts for about 1 to 2% of all causes of male infertility. Next is your testicular cause. Okay, testicular cause. Now here there is some issue with the testis itself. The testis itself is not functioning. Your hypothalamus might be alright, pituitary is alright, your ejaculatory ducts and your system might be alright. But if the testis is not functioning for whatever reason, then the patient will still have infertility, and this is called as the testicular cause. And because the testis is not working, we are going to call it as a primary hypogonadism, and this is responsible for about 10 to 15% of cases. The last one is your post-testicular defects. That means stimulus is okay, production is okay, but somehow they are not getting excreted. That means they don't go out of the human body. Alright. This also can lead to infertility because there's no point in the sperms being inside the male. It has to get out, correct? It has to get out and reach the female reproductive organs. So if that doesn't happen, it can still cause infertility. So any issue in this particular area, we are going to call this as a post-testicular defect. Here, there is problem of the ejaculatory duct and disorders of sperm transport, and this accounts for about 10 to 20% of all cases of male infertility. Now, the funniest bit is 1 to 2%, 10 to 15, 10 to 20%. They still don't account for 100% of cases. You will not believe majority of the cases, okay, majority of cases are idiopathic, where everything is normal, but they're still unable to find out what is the cause for the male infertility. This can be upwards of 60%. Okay, the majority of the cause is idiopathic. Now let's look at the pretesticular causes. That means your hypothalamic pituitary disorders. Here you can have idiopathic isolated gonadotropin deficiency, Kallman syndrome, single gene mutations, hypothalamic and pituitary tumors, or infiltrative diseases of the hypothalamus and pituitary, hyperprolactinemia, drugs, chronic systemic illness and malnutrition, infection of the glands, and obesity. Okay, all these causes can eventually lead to some sort of lack of stimulation for the testis. That's why this is called as a secondary hypogonadism. Now let's look at the primary hypogonadism or your primary gonadal disorder. That means your testicular cause. Testicular cause. So this is where the sperms are not being produced. So here that can happen because of Klinefelter syndrome, Y chromosome deletions, cryptorchidism, varicocele, infections, again drugs, exposure to radiation, exposure to environmental toxins, gonadotoxins, certain chronic illnesses. All this can affect the testis and make sure the sperms are not being produced. And the last one is disorders of sperm transport. That means the post-testicular cause. Post-testicular cause. So here there will be epididymal obstruction or dysfunction, infections obstructing the vas deferens, vasectomy, the patient has undergone a vasectomy, Carter-Genner's syndrome. Here basically there is a primary ciliary dysfunction. Apart from that, if they have an ejaculatory dysfunction, presence of Young syndrome, all these will lead to some sort of deficiency in the transport system. Okay, and this comes under post-testicular cause. Now we kept saying drugs. Let's look at the various drugs that cause your infertility. There are drugs which can impair the spermatogenesis, such as your sulfasalazine, methotrexate, nitrofurantoin, colchicine, and certain chemotherapeutic drugs. There are drugs that can cause pituitary suppression. So these can be your testosterone injections, GnRH analogs, and there are certain drugs which have anti-androgenic effects such as cimetidine, spironolactone. Drugs which can cause ejaculation failure such as your alpha blockers, antidepressants, phenothiazine. Then you can have certain drugs that cause erectile dysfunction such as your beta blockers, thiazides, and metoclopramide. So if you see this one point here, testosterone injections, this is for all those young people out there who go to the gym and to take this testosterone and steroid injections to bulk up. Please note that this can eventually lead to infertility. So please be very, very careful, because this is a very, very unregulated space where the gym instructor who has zero idea about the long-term side effects will keep prescribing all these injections and medicines. Now let's look at the etiology as per what's given in Campbell. Here basically they follow a mnemonic. The mnemonic is TICS, where T stands for toxicity, basically spermatotoxicity. I stands for infectious or inflammatory diseases. C stands for certain conditions which are there in the childhood which has led to the infertility, or S, which basically stands for sexual history. Now let's look at each of them. Under toxicity or spermatotoxicity, if the patient is on certain endocrine modulators, if the patient is on recreational drugs or on antipsychotics, opioid drugs, chemotherapy, cytotoxic chemotherapy, all these can cause infertility. Apart from that, thermal toxicity, that means your patients who have cryptorchidism, because the testis is not inside the scrotum. In the scrotum, it will be very cool, okay, but if it is inside the abdomen, there is increased temperature. This is called as thermal toxicity. Or patients who keep the laptop on their laps and keep working on it for long hours, even that generates a lot of heat, okay, that can also lead to thermal toxicity. At the same time, exposure to radiation can also cause spermatotoxicity. Coming to infections and inflammation, so basically any sort of infection or inflammation of either of these organs, such as the prostate, like chronic prostatitis, urethritis, epididymitis, or epididymoarchitis, okay, and with regards to testis, especially rubella virus, okay, basically your mumps orchitis. This is a very, very painful condition. Very painful condition. So this can also lead to infertility. Now, how does this cause infertility? Because of two ways. Either there is an anatomical problem or there is a functional problem. Anatomical problem basically means whenever there is inflammation, there is a lot of edema, there is a lot of induration, and this can block the channel. So what am I trying to say? Let us take a cut section of a vas deferens or something of that sort. Now, when it gets inflamed, there is a lot of edema that is set in. And the lumen will become narrow now. Okay, this much area will only be filled with edema. Or sometimes even this opening might get clogged off because of the infection and the secretions and the edema. Now, if this gets blocked, this can cause infertility. Okay, it's basically a blockage to the outflow of the sperms. So this is the anatomical cause. The anatomical cause for infertility. Functional cause means either of these are kind of responsible for the production of sperms or some certain secretions for the semen, especially your prostate and the testis. Okay. Now, because of the inflammation, their work tends to reduce. So if there are no sperms being produced or inadequate prostatic secretions that are being produced, this can again lead to infertility. Coming to childhood diseases, here regarding pediatric surgery, if they have undergone some sort of hydrocele or a hernia, there can be a damage to the vas deferens or the cord structures at that point of time. Or if the child has undergone a posterior urethral valve ablation in the childhood. And whenever we spoke about the posterior urethral valve ablation, we told you that only make an incision and come out, don't do a wide resection. The reason being, when you do a wide resection, there is a huge raw surface that is created. The raw surface can eventually lead to a stricture. Now, stricture will lead to a block. Block eventually means there is infertility. Okay. Then, if there is history of testicular torsion in the past. Now, if there was testicular torsion, almost 50% of them will have some sort of adverse spermatogenic effect, and in about 11% of cases, they would have developed anti-sperm antibodies. That means going ahead, these 10 or 11% will have some sort of infertility issues because of these anti-sperm antibodies, which start destroying the sperm. Okay, they start destroying the sperm, and this is seen in testicular torsion. Then, of course, if there is history of cryptorchidism or undescended testes in the past, we've already discussed that can also lead to male infertility. Last one is with regards to sexual history. Basically, you're going to ask them for the optimal timing, whether their intercourse kind of coincides with the fertile period of the woman if she's in that phase of the menstrual cycle. Second, in case they're using certain toxic lubricants, especially during their intercourse, such as KY jelly, Kerry lotion, Astroglide, saliva, okay, all these are spermatotoxic. They tend to kill off the spermatocytes. So instead, if they want lubricants which are non-toxic, they can try Pre-Seed. Okay, these are your non-toxic lubricants. So that was regarding the etiology of male infertility. So like I said, you can either classify them as pre-testicular, testicular, post-testicular, or you can classify them based on the mnemonic, that is your T, I, C and S. Now moving on to evaluation. What is the idea of evaluating a patient with male infertility? Okay, what is your role as a clinician? Your idea is first try and identify and correct the correctable causes. Identify the cause and rectify the correctable causes. So this should reverse the cause for infertility and they should be able to have a natural conception. Now, by chance, if it is a condition where you have identified but it is not correctable for some reason, let us say some anatomical abnormality, that time your job is to try and identify patients where they are in need of this intrauterine insemination or your assisted or artificial reproductive techniques. So identify the cause, then see whether this particular person can have natural conception. If they can't, then at least identify the patients or the people with infertility who are the ones who can still get pregnant with the help of intrauterine insemination or your artificial reproductive techniques. Your role is to also look for genetic abnormalities to make sure it doesn't kind of pass on to the next generation. Identify medical conditions that require special attention. And at the end of the day, if you're unable to identify or you have identified a very, very bad disease, no matter what you do, they cannot get pregnant, then you can also kind of encourage them for adoption or using a donor sperm. So this is the idea behind evaluation. Okay, first is to identify the cause, then try and correct the cause if possible. If you can't correct the cause, at least try helping them get pregnant with the help of intrauterine insemination or your ART. If that is also not possible, then eventually you are trying to see whether they fit into the category where they eventually have to either adopt the child or go in for a donor's sperm. Now, in evaluation, first you will do a good history taking, followed by a thorough physical examination, and then we move on to our investigations. In history, what all are we going to ask the patient for? One, what is the duration of infertility? And was there any previous history of infertility in the past? Now, when we talk about duration of infertility, by definition, infertility basically means in spite of having unprotected sexual intercourse for 1 year and they still don't conceive, then you're going to label it as infertility. So in short, let us say some couple comes to you within 2 or 3 months. Your job is to not start evaluating. Reassure them, tell them to wait for 1 year. They will eventually conceive through the natural methods. Next, you need to take history regarding their coital frequency and whether they are suffering from some sort of sexual dysfunction, especially like erectile dysfunction. Then, was there any previous evaluation or treatment of infertility that was carried out? Any history of childhood illnesses such as mumps, orchitis, cryptorchidism, because we know that they can have long-lasting implications in the future. Any issue with the developmental history? Was there any previous surgery and its outcomes? Was there any systemic medical illness? So what surgeries are we talking about? If there is any hernia, hydrocele, where they were in close proximity to the vas deferens, was there a testicular torsion that was rectified? So these are the information you are trying to find with the help of your previous surgical history. Then was there history of any sexually transmitted diseases or exposure to environmental toxins? And was the patient having any occupational exposure to certain recreational or very bad habits such as your tobacco, alcohol and drugs? So these are your recreational drugs like all the cocaine, marijuana and stuff like that. All these can lead to infertility. So these are the points that you are going to try to extract from the patient by taking a good thorough history. When it comes to physical examination, first do a general physical examination, then go to the local examination or examination of the reproductive system. So in general physical examination, look for anthropometry. Okay, look for secondary sexual characteristics, hair distribution and breast development. So this basically will tell you whether there is some primary genetic abnormality, like let us say Klinefelter syndrome, something of that sort, that you will be able to pick up at least some information based on these 2 points. Second, see whether the patient is obese. That is because in obesity, there is increased estrogen. So whenever there is a lot of estrogen, it tends to suppress the testosterone. Okay, suppress the testosterone. And we know that testosterone is one of the stimulants for spermatogenesis. So if there is not adequate testosterone, spermatogenesis will not take place. Next, was there reduced sex hormone binding globulin? Okay, now this can occur in obesity. Why? Because in obesity there is increased insulin. So whenever there is more insulin, the sex hormone binding globulins will reduce. So whenever the sex hormone binding globulins will reduce, so will the sex hormones. Thereby that will again lead to infertility. Next, look at the reproductive system. Start from the penis. So in penis, what are you looking for? One is hypospadiasis, second is Peyronie's disease. Now we have already spoken about it thoroughly when we spoke about Peyronie's disease. If there is a curvature which is very bad, it will literally not allow them to have a regular sexual life. Okay, so that is your Peyronie's disease. So look for that. Look for hypospadiasis, where the opening is much more proximal as compared to the glans penis. Next, palpate the testis. Okay, measure its size. That is because if it's a primary testicular failure, there will be atrophy of the testis. There is atrophy of the testis. Then examine the vas deferens and the epididymis. That is because there are certain conditions where the vas is absent since birth. The vas can be absent since birth. So this is especially seen with mutations of your CTFR gene, okay, in cystic fibrosis and stuff like that, where the vas deferens might be absent. Now, how do you examine this? In the scrotum, you can go above the testis, grab the cord structures, pull it back and feel it like this. You will be able to hold the vas because it feels like a nice tubular structure. So if you go down, pick it up and lift it up, you should be able to grab the vas in your hand. Now, if you fail to do this 3 times, that means in spite of doing this, if you are unable to grab a nice tubular structure, that means the tubular structure is not there. That is what we call as a congenital absence of the vas deferens. Okay, this can either be unilateral or it can be bilateral. So if there is failure of bringing the vas to the surface on your physical examination 3 times, then we're going to call it as a congenital absence of the vas deferens. Next, examine the varicocele. Now, an interesting fact regarding varicocele is that this is one of the most common treatable causes for infertility. This is not the most common cause for infertility, but amongst all the causes of infertility which have a very good outcome when you treat them, varicocele has the best outcome. Okay, because that is the most common treatable cause for infertility. Next, the seminal vesicle can get inflamed, can get enlarged, or let us assume there is a block in the ejaculatory duct. So seminal vesicle will kind of increase in size. So to palpate the seminal vesicle, you will have to do a digital rectal examination. Normal seminal vesicle is not palpable. Okay, normal seminal vesicle is not palpable. So if it becomes palpable, that means there is enlarged seminal vesicle. That is what they are basically trying to tell you. That means there is some sort of inflammation or infection or some sort of obstruction which is leading to the enlargement of the seminal vesicles. So I told you that you have to palpate the testis and see whether there is atrophy. Now, how will you know there is atrophy or not? Okay. So for that to happen, you can't be subject to saying, oh, I felt it is this small, this big. No, it has to be objective. You have to measure it against the standard. So for that, there is something called as the Prader's orchidometer, where they have tiny wooden balls of different size. So what you do is you're going to palpate the testis, palpate the ball, try to compare the size of the testis with each of these balls. So to whichever ball the size of the testis is comparable to, that will tell you roughly the volume or the size of the testis. So if the volume corresponds to less than 20 ml, that means it is inadequate. That means it is an atrophic testis. There is a testicular failure. That is what it means. Next is your Seeger's orchidometer. This is basically like a Verniers caliper, where you go and measure the size of the testis with the help of two calipers. Here, if it is less than 4.6 centimeters, again this is considered as testicular failure. Okay, that's considered as testicular failure. So keep it in mind, in Prader orchidometer, it should be less than 20 ml, whereas in Seeger's orchidometer, it's the length that you're going to take. If it's more than 4.6 centimeter, it's okay. If it is less than that, consider testicular failure. So now that you have finished your examination of the testis, let's go ahead and do certain endocrinological evaluation. Basically, you're trying to look for your FSH, LH, testosterone, so on and so forth. Basically, you're trying to identify whether this is a pre-testicular cause, testicular cause, or a post-testicular cause. Now, if it's a pre-testicular cause, that means from up top, the FSH is not working, the LH is not working, the GnRH is not working. That is the reason why the testosterone is not working, because there is no stimulation. So, these patients will have low FSH, low LH, low testosterone. That is why it's called as a hypogonadotropic hypogonadism or a secondary hypogonadism. Okay, low FSH, low LH, low testosterone. But if this is a problem with the testis, that means a primary hypogonadism, testis is not working, so there is no testosterone. So if there is no testosterone, there will be a positive feedback mechanism to the hypothalamus in the pituitary that increases the production of your FSH and LH. So FSH and LH have gone up. It is trying to stimulate the testis, but testis is not working. So testosterone continues to remain low. Okay. So in these patients, elevated FSH, elevated LH, but testosterone can be low or normal. This is your primary testicular failure. Last criteria is when both of these are normal and probably the infertility is lower down. Okay, that means this is not a case of hypogonadism. So here you will have normal FSH, normal LH, normal testosterone. So which basically means it can either be a normal testis and normal hypothalamus pituitary axis, but some issue with the ejaculatory duct, or rarely sometimes even a primary testicular failure, which is in a very, very mild stage, can also have similar findings where FSH, LH and testosterone are all normal. Okay. Now, what are the values that you're going to check? We have already discussed. One is FSH, one is LH. And with regards to testosterone, what you're looking for is your early morning sample, okay, of the total testosterone. Apart from that, you will ask for the sex hormone binding globulin, and albumin. Okay, because testosterone tends to bind to these structures, so you need to calculate that as well. LH, FSH we have already spoken. You will also look at estradiol. Why? Because if estrogen goes up, it reduces the amount of testosterone. That eventually will lead to a reduced stimulation of spermatogenesis. So you need to look at estradiol as well. Next, you are going to do a semen analysis. Okay. Now, in semen analysis, for proper analysis, there should be abstinence from sexual activity for 1 to 2 days. Okay, 1 to 2 days. Too long is too bad, too short is too bad. Now, if it is a very short period, okay, if there is a very short interval of abstinence, that means let us say less than 1 day or a few hours, because the sperms have already been produced and have gone out in the previous ejaculate. So, when they actually go for testing, either the volume will be low, okay, the semen volume will be low, or the sperm density, that means the number of sperm cells per ml of your semen will also be low. That is because they have just come out in the previous ejaculate. It is not yet had enough time to reproduce and come up to the value of a normal semen. Okay, that is why it might be too low. Basically saying that you're going to get a false negative value. Okay, that means you will assume the patient is infertile, but in reality it is not. Okay, so make sure you have that 1 to 2 days gap. But let us say you abstain for a very long period of time, like let us say more than 7 days, saying no, I'm going for testing for 7 days, I will not ejaculate, or we will not have any sort of orgasms where the sperms don't get out. So in such a scenario, whenever there is a longer abstinence, because the spermatocytes have not gone out, they are there only, they start dying. Okay, they start dying. So you'll have dead, immotile and morphologically abnormal sperms. So when you look at it under the microscope and you say dead cells, immotile cells, morphologically abnormal spermatocytes, then your mind starts thinking, oh, this is some issue with the sperm. Rather than thinking that it is because of abstinence, you start thinking that it's a primary spermatic issue and you will label them as infertile. So here also you can have false negative values. So remember, just 1 to 2 days is sufficient. And your diagnosis is never based on a single sample. You always have to do a reanalysis and confirm the diagnosis. Okay, so the reanalysis is usually done after 2 to 3 weeks, not before that. Wait for 2 to 3 weeks, do a repeat semen analysis and only then confirm the diagnosis. How are you going to collect the semen sample? Now these semen specimens should be collected in a clean container, okay, in a box which we normally give, right, for collecting urine sample, pus culture and all. So the same sterile container is given for collection of the semen sample. Or you can use silastic condoms, but provided the condom doesn't have any spermicidal agents. It should not have any spermicidal agents, otherwise the sperms will die. It can again give you a false negative value. And these semen samples should be examined within 1 hour after the collection. Don't delay it. Within 1 hour, look at it under the microscope on the machine and then you're going to give your result or your analysis of that particular sample that you have got. So what are the things you're going to see whenever you receive the semen sample? First is the gross. Look at the viscosity. Okay. Now the drop length is usually less than 2 centimeters in size. So this is basically something which is used for description of the viscosity of the semen. Coming to color. Normal is white in color. This is normal. White or slightly grey in color, that is normal. Yellow stands for infection. Red stands for bleeding. Brown is trauma. So these patients usually have a spinal cord injury. Okay. So trauma or some sort of spinal cord injury which has led to this brownish colored semen. Next, you're going to look at the volume, whether there is hypovolemia or whether there is adequate volume of the semen sample. Now, if there is hypovolemia, that means the amount of semen is less. Usually, this means either an obstruction to the outflow, that means the semen is being produced but it is not coming outside, or rather than coming out down, that means it will come to the prostatic urethra, then it is supposed to come down into the anterior urethra. But if the external sphincter is very tight, sometimes it starts going upwards towards the bladder. That is what we call as a retrograde ejaculation. Okay. And sometimes you might develop anti-sperm antibodies. These can cause sperm agglutination and they can decrease the motility of the sperms, thereby again being one of the causes of infertility. What are the various standards that are set below which you are going to call this as a poor semen sample, or basically this is the cutoff below which you are going to say very, very unlikely natural conception is going to happen. One is the semen volume. It should be at least 1.5 ml. The normal can be anywhere between 1.5 to 5, but less than 1.5 ml definitely means hypovolemia or less semen production. Coming to the concentration, at least 15 million sperms per ml should be there. Coming to sperm motility, there were various criteria. Now they are only looking at progressive motility. That also, if 32% of your sperms have progressive motility, then it is good, that is normal. Morphology, you need to have 4% normal forms. Looking at WBC, it should be less than 1 million cells per ml. Then this is your sperm antibodies that we just spoke about, right? So this immunobead or your mixed antiglobulin test should be less than 50%. Okay. So if all these are there, then there is a good chance that the patient will have a natural conception. That means it is not something to do with the sperm issue, must be something else. Okay, you have to look at the other causes. But if it is less than all of these, then it is primarily a sperm issue, and that has to be dealt with or addressed. So coming to the conclusion of your semen analysis, first you will look at the ejaculate volume and the pH. Okay, if it is low or absent, that means there is congenital absence of vas, ejaculatory duct obstruction, hypogonadism, or retrograde ejaculation. And this retrograde ejaculation is commonly seen after a TURP, transurethral resection of prostate, basically the prostate surgeries. So in short, what happens, you're going to have your bladder neck, prostatic urethra, and then the rest of the urethra. So this is your prostatic urethra. Your ejaculatory duct opens here into the prostatic urethra. So you have an internal sphincter and you have an external sphincter. Okay. So during TURP, they tend to sometimes damage the internal sphincter or the bladder neck. So when the ejaculate comes, we expect it to stay here and then go down. But because these are damaged, the semen or the ejaculate which comes out tends to go into the bladder and nothing comes out. So either way, there is nothing coming out. If there is an obstruction here, or if the spermatic sample is going on top, then you will still have no specimen coming out of here. So that is why I said it can either be an obstruction or it can be retrograde ejaculation. Cause for obstruction can be congenital absence of vas or an ejaculatory duct obstruction. Next, if the volume is very high, very low, we just spoke about what if it is very high. If the quantity is more, that means there is some sort of inflammation which is leading to a lot of secretions. That is why the quantity is high. Now, if you look at the characteristic, the seminal vesicles, okay, the seminal vesicles which come and empty into this is your vas difference. Okay, the seminal vesicle content are usually alkaline and they contain fructose. Now, by chance, let us assume there is a block here. Okay, now I told you the semen constitutes three different secretions, one from vas, one from seminal vesicle, one from the prostatic urethra or the prostate gland. If there is a block here, these two will not come, it's only the prostatic gland. So seminal vesicle secretes what? Alkaline secretion and fructose. Okay, so if there is a block, there will not be alkaline, instead it will be acidic. There will be no fructose, there will be no sperms because the vas difference is also blocked. Okay, so if there is an acidic semen in the absence of fructose, then the most common cause is a block in the ejaculatory duct. Okay, it's a block or a ejaculatory duct obstruction. So the same thing that we just discussed, testis produces the sperms, sends it via the vas difference. Then here you're going to have your seminal vesicle. So the vas difference and seminal vesicle combine together to form the ejaculatory duct, and that empties into the prostatic urethra, and then it is going to get out. So that is what we just read about so far. Coming to the abnormalities of the sperm, by definition, oligozoospermia basically means a reduced sperm count. Asthenoazoospermia is reduced sperm motility. Teratozoospermia, increased abnormal sperm count. How do you remember it? Teratoma. Teratoma is a tumor, which is a large tumor constituting abnormal cells. So teratozoospermia means increased abnormal sperm count. Oligoasthenoteratoazoospermia, here the sperm variables are subnormal. Azoospermia, where there is no motile sperm present in the semen. Aspermia, that means there is no ejaculate. Leukocytospermia, basically there is increased WBC count seen in the semen. So these are the various definitions that you need to be aware of. Certain times azoospermia is also defined as no sperm within the semen. Okay, even absence of sperm within the semen sometimes is labeled as azoospermia. So in short, you are going to do a semen analysis. Look for fructose, whether it is absent or not. If it is absent, most likely it's an obstruction of the ejaculatory duct. And if you think it's because of an infection, you can go ahead and do a semen culture, especially your prostatitis. If you think that is there, you go ahead and do a semen culture, you should be able to get your answer. Now we have finished the semen analysis, we go on to the genetic evaluation. Here you look for mutations within the cystic fibrosis. Like I said, here they'll have bilateral vas deferens, okay, absence of bilateral vas deferens. Then you can have testicular dysfunction in cases such as Klinefelter syndrome. So you have to look at the genetics here. Then if there are Y chromosome deletions which are associated with abnormalities of spermatogenesis. So for all those problems, you will end up doing a genetic evaluation. Now moving on to radiological investigations. Okay. In radiological investigations, one of the first thing you're going to do is a transrectal ultrasound. That is because the seminal vesicles, whatever we say, that is something that is visualized on a transrectal ultrasound. A normal seminal vesicle is not palpable and it becomes very difficult to see to the transrectal ultrasound. But if there is a palpable seminal vesicle, that means it is obstructed and inflamed or enlarged, that you will be able to visualize with the help of a transrectal ultrasound. So if it is enlarged, that means there is an obstruction of the ejaculatory duct. Okay. Next, you have a renal ultrasonography. That is because certain genetic abnormalities of the reproductive system can be associated with renal abnormalities such as renal agenesis. Renal agenesis, and that is what we're looking for, absence of kidney. Then you can do a transscrotal ultrasonography. Basically, here we're looking for varicocele or cryptorchidism or reduced size of the testis. This is the information that we are going to get whenever we do a straightforward scan of the scrotum. Next, you can do a testicular biopsy. So in the testicular biopsy, you'll get to know whether the sperms are normal. If they are normal, then probably there is an obstruction. Okay, probably there is an obstruction. That means the sperms are normal, but it is not reaching the semen. That means it's not coming outside. So that means there is a block somewhere. Now, if it is abnormal, that means there is azoospermia. That means there must be some issue with the testis. Okay, so that is the way you are going to assess after doing a testicular biopsy. Then there is a particular investigative modality where you are going to look for the integrity and the anatomy of the vas deferens, called as the vasography or the vasography. This helps to visualize the vas deferens and detect any blockages or abnormality in the vas deferens. So this is an image of a vasography. Here you can see the vas deferens like this. Okay. So this is a vasography where you are going to look at the anatomy and the integrity of the vas deferens. Now a quick recap after all we have done so far. Let us assume you have a patient of infertility where the patient has azoospermia. Okay, he's come to you. There is no sperm or very little sperm or very less sperms which are motile. Okay, and they come to you. First thing you're going to look for is whether there is presence or absence of vas deferens. Okay. Now, if there is absence of vas deferens, then you have to look for your CFTR, that is your cystic fibrosis gene. That is where you're going to have congenital absence of vas deferens. But both vas deferens are normal. That means anatomy is normal. Now, if anatomy is normal, you're going to look for quantity of semen. That means is it low quantity, high quantity. If it is low quantity, there can be two reasons. Okay, two reasons. Correct? So either the sperm is going up, that means there is a retrograde ejaculation, or there is a block here. There is a block here which is not allowing the semen to come outside. How are you going to differentiate between the two? Because in both cases after ejaculation, nothing is coming here. So how will you differentiate? You are going to do a post-ejaculation study. Okay? During ejaculation, nothing will come, I agree. Afterwards, this sperm which has gone into the bladder, got mixed with the urine, eventually has to come out. So whenever you do a post-ejaculatory study, okay, or a post-ejaculatory urine analysis, if you find sperms, okay, if you find sperms within the post-ejaculatory urine analysis, that means that this was a retrograde ejaculation where it had sat in the bladder and then it is coming out. Okay. Now, if by chance the sperm is seen in your post-ejaculatory urine analysis, you're going to call it as a retrograde ejaculation. Now the terminology here is a bit different. Don't get confused. What they have said here is sperm absent on urine analysis. No, it is present. So if there is no absence of sperms, then you're going to call it as retrograde ejaculation. If there is absence of sperms, that means there is no sperm coming out even in the urine at a later stage, then you're going to look for ejaculatory duct obstruction. So that is when you're going to do your transrectal ultrasound and all. Now let us assume the semen volume is normal. Okay, it is not less. It is a good semen volume. Now you have to look for whether it is a issue with the testis or it's an issue of your hypothalamo-pituitary axis. So look at the size of the testis. Size of the testis is normal, but FSH is low, then think of obstruction. If it's the other way around, size of the testis is small, that means it's an atrophic testis. It's an atrophic testis. But FSH is normal or elevated. That means it's a primary testicular failure. So here there is a spermatogenic dysfunction. That means the actual testis itself is not functioning. So this is how you basically evaluate a patient with male infertility. Coming to treatment, most of the times these are managed with some sort of medications. So if it is a hypogonadotrophic hypogonadism, that means this is a secondary hypogonadism. That means some issue with the hypothalamo-pituitary axis. Here you can treat them with pulsatile GnRH, clomiphene citrate, tamoxifen, HCG, HMG and testosterone. Or if it's the other way around, that means it is a primary testicular failure. That means the testis is not functioning. So these are candidates where you will have to think of the artificial pregnancy, okay, where you can't have it through natural conception like the IVF, ICSC, using a donor sperm or adoption. Or sometimes you can use androgen, FSH, clomiphene. And to control hyperprolactinemia, you might have to give them dopamine agonists. Strict control of diabetes mellitus or hypothyroidism. All these are options available whenever you are dealing with a primary hypogonadism or an initial problem that is in the testis. Okay. Next, let's look at a condition where pituitary is normal, hypothalamus is normal, testis is normal. Let us assume even the pathway is normal sometimes, but there might be an issue with the sexual functioning. Okay. The act of intercourse itself might be faulty. So if there is erectile dysfunction which the patient is suffering from, you can give them a PDE5, that is a phosphodiesterase 5 inhibitor such as a sildenafil. If they have ejaculatory problems, especially a retrograde ejaculation, you can give them imipramine, pseudoephedrine or ephedrine or even a phenylpropylamine. Or if they are having conditions such as retrograde ejaculation, neurogenic impotence or severe hypospadiasis, you can try intrauterine insemination. That means testis production is normal, but they are having difficulties getting this produced sperms. That means the sperms which are produced to get it outside is becoming an issue. So you will remove it and make sure it reaches the uterus through the intrauterine insemination technique. Finally, your post-testicular treatment, wherever we are facing some sort of obstruction to the epididymis or the vas. Some sort of obstruction to the epididymis or the vas. So here you have various conditions like MESA, PESA, TESE, TESA. MESA basically stands for microsurgical epididymal sperm aspiration. Okay. PESA stands for percutaneous epididymal sperm aspiration. TESE basically stands for testicular sperm extraction. And TESA stands for testicular sperm aspiration. So in short, if it is blocked and you can't rectify the block, at least remove the sperms from there, keep them ready for your intrauterine insemination. That is what the idea is. So for that you have various techniques, MESA, PESA, TESA or the TESE. Now this is an image where you can see they have kind of gone inside the testis and they are aspirating the sperms and coming out. Okay. So this is one of the techniques of trying to extract the sperms from the testis. Coming to the surgical treatment, this is the last one that we're going to talk about. We don't commonly perform or we don't commonly use these techniques. First is your vasovasostomy. That means vas deferens to vas deferens anastomosis. This is most commonly performed after a vasectomy. For some reason, they have undergone a vasectomy. Now they are trying to recannulate it. Okay, they are trying to recannulate it. That is what we call as a vasovasostomy. Apart from that, they can do a vasoepididymostomy. That means vas deferens to the epididymis. Now there are various procedures for this, where you take the vas from one testis and put it to the other testis, or where you move the testis to the opposite hemiscrotum and do an anastomosis. Or sometimes when you need length, you can kind of unwind the vas deferens, because we know that the testis is like this, epididymis comes here and then the vas goes up, correct? Like this. So what they do is they release these adhesions. They release these adhesions whenever you need length. So the testis is like this, epididymis is here, and the vas deferens goes up straight. So you will gain that extra length. So all these are various techniques of trying to achieve enough length to make sure you have a tension-free anastomosis. Apart from that, if it's an ejaculatory duct problem, you can do a transurethral resection of the ejaculatory ducts. Basically, it is something similar to that of a transurethral resection of the prostate, because ejaculatory ducts excrete or kind of exit into the prostatic urethra. So once you're inside the prostatic urethra, you might as well scrape it off and remove that block. Then if there is a varicocele, you can do a varicocele repair. You can either do a laparoscopy or an open approach. Okay, the open is also called as a microsurgical approach. This is usually a subinguinal approach. Apart from that, if you can do an orchidopexy for cryptorchidism, you're going to try and pull it down to try and improve the fertility, or a vibratory stimulation surgical procedure. Okay, this is for patients who have some sort of issues with regarding the functioning of the sexual activity. So this was regarding the surgical management of your male infertility. So it's a very kind of a confusing sort of topic, because there are a lot of etiologies that we have to deal with. But what you guys need to know or kind of have to remember is the basic flow chart, how you are going to deal with azoospermia. What do you mean by secondary hypogonadism? What do you mean by primary hypogonadism? How are you going to go ahead with your treatment per se for these patients? Which are the patients that need your intrauterine insemination or your artificial reproductive techniques? And when you are going to plan a surgical procedure. So with that, let's wind up this particular module. All the very best, study well, and I'll see you soon.